So respected doctors, so today's topic will be on the management of the complications and special situations in the hypertension. Okay. So in the next few minutes, we will be talking on various complications in the hypertension and its management. So this is an important slide showing you that the role of the hypertension as far as the mortality and the morbidity is concerned in Indian population. See, in fact, hypertension is the #1 killer in the world. Whereas in India, we are having other risk factors also which are associated with the high morbidity and the mortality, like dietary risks, air pollution, malnutrition, diabetes, unsafe water, sanitation, hand washing, smoking, alcohol abuse, and dyslipidemia and obesity. See, these are the very important reasons to cause more and more morbidity and the mortality in India. And among all the diseases, I think the hypertension is the most important killer as far as these risk factors is concerned. So it's very easy to diagnose hypertension with your sphygmomanometer. We can easily diagnose the hypertension, and we don't require any high-tech investigations like CT or MRI to diagnose an hypertension. But one thing is very clear. So we have to identify the hypertensives in the society, because hypertension is the most asymptomatic disease and found to be an hypertensive. So definitely there is a big role for your dietary approach, your exercise, your yoga, meditation. So this is the non-pharmacological management of hypertension has to be initiated from the day one itself, provided if the person is in the stage 1 hypertension. And suppose if the person is in the stage 2 or the stage 3, so definitely they require medication even from the day of the onset of the diagnosis. See, these are a lot of the complications of the hypertension. So crisis, retinopathy, CKD, PAD, stroke, coronary artery disease, heart failure, aortic aneurysms. So these are the different complications of the hypertension we often see in our society. And out of them, the most important are the coronary artery disease, CVA, CKD. These three are very, very important, because most of the admissions in the medical units or the cardiology units or the neuro units are in the ICUs. Almost in the, as far as the medical cases are concerned, 60 to 70% are either because of the coronary artery disease or the stroke or the CKD needing the dialysis. So these are the very important complications of the hypertension. All these complications can be preventable. So early onset of the early diagnosis of the hypertension and the early interventions, either with the non-pharmacological or pharmacological, and then good follow-up. So definitely we can avoid or we can prevent the complications of these hypertension. See, the vessel atherosclerosis, premature atherosclerosis, and aneurysms, aortic dissections are very common because of the endothelial dysfunctions, etc. And as far the kidneys are concerned, proteinuria is very important. Sometimes in a hematuria. And finally, there will be elevation of your creatinine levels. So then the CKD, earlier we considered as the uremia, now it is the CKD, chronic kidney disease. And then in the heart, so LVH is the most important thing. And myocardial infarction is very common. So most important risk factor for the myocardial infarction, out of the 5 major risk factors, hypertension is the one, and other 4 are diabetes, dyslipidemia, obesity, and the smoking. As far as the brain is concerned, you have the infarct or the hemorrhage, that is the CVA. So both the forms of the CVAs are very common in hypertension, both the thrombosis as well as the hemorrhage. And some people, they are present with hepatic encephalopathy, hypertensive encephalopathy with seizures. And there is a multilacunar infarcts and dementias, early onset of the Alzheimer's disease, etc. is very common in hypertension individuals, finally leading to the strokes and the transient ischemic attacks. Retina is also very important, so one should be screened for the fundus. So what about the artery, what about the retinal artery, retinal vein, AV nicking, and then the silver wire appearance of these venules or the arterioles. And there is a dot hemorrhages, and then the exudates, optic edema, so optic disc enlargement. So these are the very important points to be noted or seen in your fundus examination. So nowadays we are not seeing the fundus, but anyhow, so definitely we have to send these cases to the ophthalmologist for the dilated pupillary examination and see the fundus examination. So this is a very important. So the complications of the hypertension are many. Unfortunately, lot of our hypertensive individuals, they are getting these complications just because of their ignorance, just because of their poor follow-up, because of their late diagnosis of the hypertension, and what can I say, and improper uptitration of the medications. See, one fellow diagnosed with hypertension in 2005, and you advise some telmisartan 40 mg or the amlodipine 5 mg. So he has been taking the same tablet all these years. So that should not be the story in an hypertension individuals. There should be a regular follow-up and uptitration of the dosages. Suppose even after the your medication, initial medication, if the blood pressure continuously above the 140/90, again you have to uptitrate the dose, or you can add the another drug. So the combination drug therapy is also very much needed in the management of the hypertension. So the same thing here, if you see the kidneys, proteinuria, and then thickening of these nephrons, nephrosclerosis, and leads to the CKD. And the heat map, you can consider the staging of these diseases, chronic kidney disease and its prognosis. And finally, if the GFR is less than the 15, so you consider as the end-stage renal disease, that is stage 5 of the CKD, where only the replacement is the only treatment of the choice, either your dialysis or your kidney transplantation. In the heart, the most important thing here is the left ventricular hypertrophy. So that is the reason all the hypertensive individuals, they should get an ECG, and we can easily diagnose the LVH in an ECG in most of the times. And sometimes we can, even though if the ECG is the normal, so if you subject the case for your 2D echo, then your left ventricular mass index and left ventricular size, and there is any eccentric hypertrophy or concentric hypertrophy of the left ventricle can be easily detected with the 2D echo examination. So finally they will say this ejection fraction. If it is low, it is the ref, that is the reduced ejection fraction. If it is the normal, mostly the heart failure of diastolic dysfunction. And angina and coronary artery disease, so the LVH is an independent risk factor to cause the IHD, to cause the heart failure, to cause the arrhythmias. So angina and coronary artery disease finally leads to the myocardial infarction. So again, ST elevated or non-ST elevated, and then you get the troponin, you get the CPK-MB, and then the subject for the primary PTCA with the international cardiologist approach. And if there is a triple vessel disease or a left main coronary artery block, so definitely they are the candidates to go for the coronary artery bypass. That is how we treat these cases. Unfortunately, with a lot of the cath labs and the cardiologists and the CT surgeons, so nowadays the outcome of these myocardial infarctions is very, very, very good, provided if they present in the good ideal period. Atrial fibrillation and ventricular arrhythmias, so these are also very common. These are the tachyarrhythmias. So here you should use the beta blockers as the compelling drugs to use in tachyarrhythmias, most probably maybe the bisoprolol. And left untreated because of these elevated heart rate, so they will go up, they will end up with the heart failure. And in the initial days, a good recovery with the medical management, and a later time, so they may need a cardiac transplantation also to the end-stage cardiac heart failure disease. As far as the brain is concerned, so you have the retinopathy and you have the other lesions in the white matter, so there leads to the dementia and the transient ischemic attacks when the carotid arteries are blocked, anterocerebral artery or posterior cerebral artery or middle cerebral artery, And some people without the uncontrolled hypertension or accelerated hypertension, they may subject for the hemorrhage also. Sometimes an intracerebral hemorrhage, sometimes the subarachnoid hemorrhages. So these are all the different strokes we see it in the anterior cerebral artery stroke or middle cerebral artery stroke and the posterior cerebral artery stroke. Usually the hemiplegia because of the middle cerebral artery block, and maybe the cerebellar signs or symptoms are mostly because of the posterior cerebral artery occlusions. So what is the target blood pressure? So is it less than the 140/90 or less than 130/80? So in Indian population, as we are having the more cases of the hypertension and diabetes, heart failure and CKD, etc., it is always ideal to keep the blood pressure less than 130/80 in most of our individuals. Very few individuals, the young individuals without any comorbidities, without any past history of the vascular diseases or non-smokers, ideal body weight, then you can plan for the 140/90, less than 140/90 as your target. But in our clinical practice, most of our patients, they turn to be in this group of less than 130/80 target blood pressure. Who are they? So the people with the coronary artery disease, peripheral arterial disease, abdominal aortic aneurysm, left ventricular hypertrophy, you have to keep the blood pressure target as less than 130/80. So if the person is having the target organ damages, so like proteinuria or the LVH, etc., so you have to keep the BP target as less than 130/80. And the multiple risk factors, already told you the several major vascular risk factors like diabetes, hypertension, dyslipidemia, obesity, smoking, etc. And some people, they have the non-traditional risk factors like hyperhomocystinemia, hyperuricemia, albuminuria, carotid intima media thickness, more and more calcium score, coronary calcium score more than 400, and ankle brachial index less than 0.9. So these are the candidates with the multiple risk factors, that are non-traditional risk factors. So when they are having the more and more risk factors, multiple risk factors, so definitely ideally to keep the blood pressure as low as possible. So diabetes mellitus is a big vascular disease. You have to keep the blood pressure less than 130/80. CKD with albuminuria, so definitely it's very difficult to keep the blood pressure at 130/80 in the CKD population, because you need a lot of the drugs in CKD. You need the nifedipine, so maybe 20 milligrams TAD. You need alpha blocker like Minipres XL, that is prazosin, or Prozopres XL, maybe 2.5 mg or 5 mg TAD, and you may need the central acting drug like Arcamin, 1 milligrams maybe OD or the BD, and you may need the loop diuretics like your furosemide or the torsemide, high dosages, maybe 40 milligrams BD or 80 milligrams BD. So this is how we have to keep the blood pressure, and you have to use the 5 or 6 molecules in an established CKD with hypertension to keep their target at 130/80. It is very easy to say the target, but very difficult to keep the blood pressure at 130/80 in all the CKD population. So the major recent evidences like a SPRINT study, you all know the SPRINT, so that has given a lot of importance to keep the systolic blood pressure less than 120. So they have studied the few people whose systolic blood pressure more than 120, and those people who are whose systolic blood pressure less than 120. So less than the 120 of the systolic, they are getting the less vascular events. So that is the impression of your SPRINT study. So SPRINT study says that intensive BP control always better, but of course there are few exceptions like very elderly individuals with a lot of the comorbidities, or individuals with CKD. So definitely you have to see that the systolic 120 is not ideal. So definitely you can keep at 125, 130 or 135, 140. But usually in majority, 95% of the individuals, you have to keep the systolic blood pressure as close to the normal as possible. And as you all know that the normal systolic blood pressure is 120 or less than 120. STEP study, that is a strategy of the blood pressure intervention in the elderly hypertensive patients, that also gives the same impression. And the ACCORD, you all know that ACCORD action to control the cardiovascular risk in diabetes. So this is a study done in the diabetics. So in whom if you keep the blood pressure to less than 130/80, you are getting the more benefits as far as the vascular risk is concerned. So these are the target blood pressure people and the recent evidences. See the risk factors is male more than the 45 and female more than the 55. So the females have the advantages till they get the menopause. So this estrogen is very, very protective as far as the vascular injury is concerned. So the postmenopausal women, again the risk is as equal as the males, and some individuals, some females after the menopause, the vascular risk may be much more than their counterparts. And family history of the early cardiovascular and cerebrovascular diseases in the males less than 55 and the females less than the 65. If any one of their family member they died because of these vascular events, either the MI or the CVA or aneurysms or etc. So definitely this individual is also at risk of getting the premature atherosclerosis and the strokes, and you have to keep the blood pressure, and also you have to see other comorbidities, other major vascular risk factors also in along with your hypertension management to keep him alive for few more decades. Otherwise, no. So these events occurs in the families, occurs in the same age groups. Smoking is very, very dangerous as far as the vessels are concerned. In any form of the smoking, whether it is BD or cigarettes or cigars or gutka or pan parag, etc. So these are all dangerous. Obesity. So you all know that in the Indians, obesity means BMI more than 23. So normal BMI for us is the 23. More than 23 is either overweight or the obese. So definitely, unfortunately, India is the capital of the obesity, world capital of obesity, because a lot of us, not all of us, are having the obesity because our BMI is more than 23. Even though the BMI is less than 23, we are having the abdominal adiposity. So this abdominal adiposity is more of the visceral fat and is more atherosclerotic. And dyslipidemia is very important. So you have to keep the LDL not at 100 or 130 or 80 or 70, but it's ideally to keep at 55, around 50. And again, it is very difficult to reach the LDL target of the 50 with your 10 milligrams of your atorvastatin or the 5 or 10 milligrams of the rosuvastatin. So you have to use the high intensity statins here, at least 40 milligrams of the atorvastatin or 20 milligrams of the rosuvastatin. See the pre-diabetes, it is of the two types. One is the IFG, that is impaired fasting glucose, where the fasting blood sugar is between 101 to 125. So if the fasting blood sugar is less than 100, they are the normal. 126 or more than the 126, they are the diabetics. 101 to 125 are the pre-diabetics. And another pre-diabetic situation is impaired gastric tolerance, that is IGT. So where the postprandial blood sugar is between 141 to 199. So the postprandial 200 and more than 200 is a diabetes, and postprandial less than 140 is the normal. So between 141 to 199, they are again IGT, impaired glucose tolerance, again the pre-diabetes. So why I am saying all these things is you should be familiar and should remember all these figures, because when the fellow is sitting before you with a postprandial blood sugar of 160, so don't consider him as a normal. So normal means postprandial less than 140. So 166 postprandial is pre-diabetic. And this pre-diabetic is an independent risk factor to cause the vascular damage. In the same way, when the fasting blood sugar 110 is not normal, so 110 is pre-diabetic. So less than 100 is the normal, more than 126 is the diabetic. So you need not treat these people with the drugs. But definitely, you have to say that you are in the pre-diabetes. There are the high chances of getting into the diabetic fold. So the only way to prevent the pre-diabetes is your good dietary approach and good exercise, good sleep pattern, and avoidance of the smoking and alcohol, etc. So all the non-drug measures or non-pharmacological measures has to be implemented in all these pre-diabetic individuals, because in India right now about 10.3 crores of the diabetics and nearly 13 crores are the pre-diabetics. So the conversion of the pre-diabetics to the diabetes is very high in Indian population when compared to the Western population. In Western population, the conversion of the pre-diabetes to the diabetes is to the tune of about 15 to 18%, whereas in India to the tune of about 70 to 85%. So in India, today's pre-diabetic is definitely tomorrow's diabetic. But we have to postpone this conversion, and sometimes now we have to reverse the diabetes is also possible with your intervention. So then the target organ damage. So already I told you what are all the target organs, like your eyes, retina, your kidney, your heart, your brain, your vessels. So there will be the periventricular white matter hyperintensity if you take any CT scan or an MRI, and there will be the microbleeds, asymptomatic stroke, left ventricular hypertrophy, albuminuria. This is the very important, because CKD population is also increasing in India like anything, and the two reasons to cause CKD in India are diabetes and hypertension, and unfortunately both are very good combination. So this deadly DO in India is diabetes and hypertension. So all the urinary albuminuria individuals, they should be treated with either ACE inhibitors or ARBs to give a good renoprotection. Otherwise, within a few months or the years, the creatinine starts rising, and finally they will end up with CKD and stage 5 or CKD in the next 5 years to 10 years down to the line. So don't underestimate the value of the albuminuria in all our hypertension individuals. So get the test of urine albumin and also get the test of USCR, that is urinary albumin creatinine ratio. That is much more important than the simple urine albumin. So USCR is urinary albumin creatinine ratio. If it is elevated, so definitely you have to tell to the patient that you are at risk of getting the CKD in the next few decades. So not to have the CKD, so use the ACE inhibitors, ARBs in them, control the blood pressure very aggressively, control the blood sugars, control the lipids, and avoid the smoking. So these are the measures you have to take it. Otherwise, again, these people will turn up into the CKD. And of course, low GFR is nothing but elevated creatinine levels, erytheromatous plaque. So that can be known with your, if you send the Doppler study of your carotids. In the same way, the Doppler study is a Yankel brachial index. You can assess the erytheromatous plaques in the arteries. So carotid femoral pulse wave velocity, brachial ankle pulse wave velocity, coronary artery calcium score. This is the very important investigation nowadays. So this is the coronary artery calcium score. Usually it should be 0. So normal value is 0. So if the calcium score is more than the 1 or more than the 1, so definitely these people are at high risk of getting the atherosclerotic plaque formation. So we have to take a lot of interest in them, in advising your dietary approach, your exercise, your meditation, yoga, etc. And also a good management with your high intensity statins, maybe 20 milligrams of the rosuvastatin or 40 milligrams of the atorvastatin. And then at a high risk individuals, again an antiplatelet agents like your aspirin or the clopidogrel, don't require both, but definitely one of these two molecules is important in high risk individuals. So definitely we can give a good quality of the life, and you can prevent the early onset of the coronary artery disease if you tackle them. And of course, hypertensive retinopathy. So grade 3, grade 4 are very dangerous, very high. So again, the treatment for this hypertensive retinopathy is control the blood pressure very effectively, and your dietary approach, and maybe some antioxidants. So they don't require any interventions at this stage. And if the person is having the more and more retinopathy, so definitely we have to subject them to the retina surgeons. Unfortunately, we are having quite a good number of the retina surgeons in most of our places, and they are playing a lot of vital role in preventing the blindness in these individuals. So move on to the hypertensive crisis. This is divided into two groups. One is urgency and emergency. So crisis is nothing but systolic blood pressure more than 180 or the diastolic blood pressure more than the 120. So when an individual's BP is more than 180 by 120, he is in crisis. This is divided into the urgency and the emergency. Urgency, no target organ damage. You can treat it outpatient with an intensive management with your antihypertensive medications. Whereas emergency means a target organ damage is there. So you have to admit the patient, and you have to reduce the blood pressure as early as possible. So that is the difference between urgency and emergency. So you combine these two, that is hypertensive crisis. Urgency means systolic blood pressure more than 180, diastolic more than 120 without target organ damage. Emergency, systolic more than 180, diastolic more than 120 with target organ damage. Urgency, no need of admission. Emergency definitely needs admission. In urgency, slow and steady in reducing the blood pressures, whereas in emergency, so within few minutes to the hours, we have to reduce the blood pressure. Otherwise, these target organ damage, so they are the potential candidates to go for the myocardial infarction or the strokes or aneurysms. See severe uncontrolled high blood pressure, evidence of the hypertension mediated organ damage in the vital organs. So you can remember the word BARK, B-A-R-K-H. B stands for brain, A stands for arteries, R stands for retina, K stands for kidney, and H stands for the heart. So this, if the BP is very high, left untreated, so definitely attacks these organs, important organs in the body. What happens in the brain? So stroke. So it could be a thrombotic stroke or an hemorrhagic stroke. In all the accelerated hypertension, very high blood pressure, the chances of getting the hemorrhagic strokes are very high. Whereas in the stage 1 and the stage 2 hypertension, the thrombotic CVAs are very common. Yes, very few people are in the very high blood pressures. So stage 3 or stage 4, stage 3. So that is the reason 80% of the strokes caused by the hypertension are the thrombotic, whereas the 20 to 25% are the hemorrhagics. In the arteries, acute aortic syndromes, that is aortic aneurysms, are the eclampsias and preeclampsias. So retina is a retinopathy. The name given to this retinopathy, big thanks to these three scientists, Keith, Wegener and Barker. So Keith, Wegener and Barker retinopathy. In the kidneys, you can have the acute renal insufficiency or the thrombotic microangiopathy. So either AKI or the CKD, and CKD is much more common in the hypertension individuals. And some people with very high blood pressure, they may land up with acute and chronic kidney disease. So they may need 1 or 2 shots of the dialysis, and then definitely they need the further medical management. So one word about this CKD is, these CKD individuals, they die in the hands of the cardiologist rather than in the hands of the nephrologist. Because once the creatinine is 2 or 3 or the 4, the chances of having the ischemic heart disease is much high. So most of these people with the CKD, so they die before they reach the stage of hemodialysis. Heart, so you have all the 3 things in the heart. One is ischemic heart disease, so acute myocardial infarction. One is heart failure, so acute heart failure or the chronic heart failure, and pulmonary edema, and then tachyarrhythmias. So these are the very, very important hypertensive emergencies. Here the rapid BP reduction with IV drugs chosen according to the BARC, and we have the hydralazine, we have the esmolol, we have the enalapril in the IV. But usually you need the IV therapy to reduce the blood pressure. If the patient is comfortable and patient is conscious, so definitely we can control these blood pressures very effectively even with our oral medications. But one thing is very clear, in all these emergencies you need a combination drug therapies or a multiple antihypertensives. For example, they need diuretic therapy, so we give 1 or 2 ampoules of your Lasix, and we give the NTZ drip, so nitroglycerin infusions, and we give the niprophin, maybe 10 milligrams or 20 milligrams, or amlodipine or 10 milligrams or the 5 milligrams, and then we need the stelmisartan, maybe 40 mg or 80 mg. So this is how we treat these individuals. So giving at higher dosages and regularly monitor the patient with frequent BP recordings. See, if the fellow is having a possible hypertensive emergency, so that means the systolic is more than 180, diastolic more than 120 with target organ damage. So is there a known cause of the hypertension like preeclampsia? So that means the pregnancy and proteinuria, that is preeclampsia. aortic dissection, the severe chest pain radiate into the bag, and it can be easily detected with your echo, 2D echo, and symptomatic crashing, acute pulmonary edema, myocardial infarction, stroke, scleroderma renal crisis, symptomatic intoxication, hyperthyroidism, uncontrolled pain, or the urinary obstruction. So, if these are present, yes, the secondary hypertension, evaluate and treat using the specific strategies unique to the underlying condition. If all these things are negative, meet the criteria for hypertension emergency, target organ damage, so acute kidney injury or myocardial infarction or encephalopathy, etc. Or in the severe hypertension with the mean arterial pressure 135. What you mean by the mean arterial pressure? Mean arterial pressure is equal to diastolic blood pressure plus 1/3 of pulse pressure. If the diastolic blood pressure is say 150 or 160 or 180, that plus 1/3 of the pulse pressure. So pulse pressure is a difference between systolic and the diastolic. Suppose 200 by 150. So the difference is 50. 50 by 3. So maybe 17 or 18. So that you add 17 or 18 to your 150 of the diastolic, then it may be 167 and etc. So that is the mean arterial pressure. If it is more than 135, varies depending on the baseline blood pressure. If chronic hypertension, the BP should be well above the patient's baseline. If these are the not an emergency, it may be an urgency. So no need for immediate BP management or inpatient admissions. If the patient is having concern the symptoms, then look for an alternative explanation for them. Suppose a patient is in the target organ damage. So definitely this is an hypertensive emergency. So reevaluate for an underlying disease process causing the hypertension. Consider the CT head to rule out the hemorrhage, not to pick up the thrombosis, because to pick up the thrombosis in the CT head, you need to wait for at least 8 to 10 hours to get the changes in your white matter and the gray matter. Whereas for an hemorrhage, immediately you can identify the hemorrhage. So in all the CVAs, we get the immediate CT not to confirm the diagnosis of the thrombosis, but to exclude the diagnosis of the hemorrhage. Because if it is a thrombosis, you are supposed to use the aspirin and the clopidogrel at higher dosages. Whereas if it is an emergency, if it is an hemorrhage, so we should not use the aspirin or the clopidogrel. Whereas in both the situations, you can use the statins. Evaluate for other causes as appropriate, like aortic dissection, intoxication. Aggressively treat any possible precipitating factors like pain, agitation, volume overload, withdrawal, etc. Persistent severe hypertension with no clear cause. Then the primary hypertension emergencies, IV antihypertensive treatment is indicated. Immediate BP control with antihypertensive medications like nicardipine infusion. So we don't use the nicardipine infusion here. You have the hydralazine, you have the esmolol, you have the enalapril. Typically target the 20% reduction in the mean arterial pressure within 1 to 2 hours. After the BP control and the clinical improvements, so transition to the oral antihypertensives. Gradually transfer from the IV to the oral antihypertensive medications. Now the pregnancy hypertension. The drugs of the choice in treating the patients with hypertensive crisis and eclampsia, preeclampsia are hydralazine, labetalol, and nifedipine. So don't use the diuretics in pregnancy. Don't use the ACE or ARBs. These two are very much contraindicated in pregnancy associated hypertension. Diuretics and ACE inhibitors or ARBs. You can safely use the calcium channel blockers. You can use the combined alpha and beta blockers like labetalol. And sometimes you can also use the beta blockers like your bisoprolol. Angiotensin converting enzyme inhibitors are blockers, direct inhibitors, sodium nitroprusides, and diuretics. They are contraindicated while treating these patients for the hypertension. Here, 22-year-old primee presents for the routine checkup at 28 weeks of the pregnancy. She has a family history of the hypertension in both the parents. So her age is 22 years, a primee. Routine checkup at 28 weeks of the pregnancy. A family history of the hypertension in both the parents. Right arm 150 by 100. multiple occasions on the same day and over a period of the 3 days. Edema of feet present. So what investigations will you order for this patient? So with an hypertension, with a strong family history of hypertension, the parents, pregnancy, edema of the feet, so definitely you should suspect the preeclampsia and eclampsia and get the urine proteins and then the creatinine functions, kidney functions and also the liver functions and get an ECG. So what investigations will you order for this patient? How would you manage this patient? So what investigations? The urine analysis for the protein. So it could be both the spot and the 24 hours. So as I told, the spot means urinary albumin creatinine ratio. 24 hours you collect the 24 hours urine and subject for the 24 hours urine protein estimation. So complete blood count including the platelets, creatinine levels, uric acid, hyperuricemia is again a renal risk factor. Serum transaminases, SGPT, SGOT and coagulation profiles. Urine analysis reveals the proteinuria here, 578 milligrams for 24 hours. So the normal is 30 milligrams, up to 30 is the normal way. How would you manage this patient? So plan for the preeclampsia with your good antihypertensive medications. So the terminology used for the hypertensive emergencies, definition and incidence at the emergency departments. See, severe hypertension, severely or markedly elevated blood pressure, more than 180 by 120 and acute end organ damage, injury absent. Hypertensive emergency, so acute end organ injury present due to the severe hypertension. Here the end organ damage is there in emergencies. So immediate BP lowering is clinically beneficial. Neurologic, so you can have the encephalopathy, you can have the intracellular or subarachnoid hemorrhage or thrombotic strokes. Cardiovascular, acute heart failure or pulmonary edema, acute myocardial infarction or acute arrhythmias, aortic dissection. Obstetric, preeclampsia and eclampsia and others, acute kidney injury, thrombotic microangiopathy, acute moderate to severe hypertensive retinopathy, and acute medical emergency with associated severe hypertension, acute end organ injury is present. Severe hypertension is not a direct cause of injury and immediate BP lowering is not clinically beneficial. So urgency already told you, high blood pressure 180 by 120 without target organ damage. Crisis, both emergencies and urgencies is the crisis. Malignant hypertension is microvascular injury with organ damage in 3 or more target organs. That is the malignant hypertension. So acute hypertension mediated end organ damage in the malignant hypertension. There is the more organs are involved in the malignant hypertension, target organ damage. See severe uncontrolled hypertension. So the pressure induced natriuresis. So they involve the RAS activation. And increase in the vascular resistance. So the microcirculatory damage. Autoregulation failure. So it leads to the target organ damage. This accelerated autoregulation failure may cause microcirculatory damage and microcirculatory damage also can cause autoregulation. This is a bidirectional. So in malignant hypertension, a sudden increase in the vascular resistance and pressure induced natriuresis trigger a vicious cycle leading to the renin-angiotensin system activation and a further increase in the blood pressure and microcirculatory damage. Autoregulation failure and microcirculatory damage are at the foundation of the target organ damage associated with the malignant hypertension. So the RAS and the renin-angiotensin system. What are the goals of the therapy in these emergencies? All patients in the hypertension emergency should be hospitalized because they are having the target organ damage. Immediate and controlled blood pressure reduction. Reduce the BP less than 25% within minutes to the hours, 1 hour. If the BP is then stable, so target toward the 160 systolic and 100 to 110 diastolic over the next 2 to 4 hours. If this level of the BP is well tolerated and the patient is clinically stable, further gradual reductions toward the normal BP can be targeted over the next 24 to 48 hours. Exception is an acute ischemic stroke. See, emergency means target organ damage. If the person is found to be in a stroke, again divided into two groups. One is the hemorrhage and the thrombosis. It is very difficult clinically because some of the thrombotic stroke population may be in the deep comatose. On the other hand, some of the hemorrhagic strokes, they are totally conscious and coherent. So it's very difficult to know whether it is a thrombotic stroke or an hemorrhagic stroke clinically. So every stroke, they need a CT must. CT is must. So that is the reason within no time one should get the CT to exclude the hemorrhage. BP lowering is not indicated if the diastolic blood pressure is less than 120 or the systolic blood pressure is less than 220 unless planned for the thrombolysis. See here in the ischemic stroke, you need to understand the ischemic zone and the necrotic zone. So in the ischemic zone is called as the penumbra. If you reduce the blood pressure very effectively, this ischemic zone, there is a penumbra zone, is furthering increasing its size, and the necrotic zone will be much more necrotic. So we are giving more, we are doing more harm to the patient by reducing the blood pressure very effectively in an ischemic strokes. So by keeping the BP at a higher level, you are making more and more blood supply to the ischemic zone. So that is how the ischemic zone will be reduced and the necrotic zone will be well maintained or reduced in its size. So the take home point is in all the ischemic strokes, so don't reduce the blood pressure very effectively. Keep the systolic blood pressure higher, keep the diastolic blood pressure higher, much higher, maybe systolic around 160 to 180, diastolic maybe 110. So that is the ideal blood pressure to make the ischemic zone to get more and more vasculated. So that is how we can reduce the zone of the penumbra in the ischemic strokes. So even in the ICUs or in the casualty, most of the people, when they are having the blood pressure, when they have the high blood pressure and the stroke, immediately they keep one tablet of the depine sublingually. So that causes more harm rather than the good. So avoid the sublingual nifedipine in all these emergencies. Rapid lowering of the BP can impair the cerebral circulation in the thrombotic strokes. So urgencies means without target organ damage can be managed with the oral potent antihypertensive combination therapy or the treatment of the choice. Now we have the beautiful molecules. We have the 80 milligrams of the telmisartan, 10 milligrams of the amlodipine, and then the 12.5 milligrams of the chlorthalidone. These are the available 3 drugs. So you can choose them. Sublingual or rapidly acting nifedipine must not be used, as it can lower the BP acutely and lead to the cardiac arrhythmias and the death. 55-year-old male, a non-smoker, with no history of the diabetes and goes for the walks regularly, presents with the non-specific symptoms of the giddiness. See, 55-year-old male, non-smoker, no history of the diabetes, is on regular walk, complaining of the giddiness. Pulse 66, regular, BP 220 by 132. Okay, and the standing BP 228 by 120. See, with this BP, he is having a symptom of giddiness. So some people know with this BP, they may present with an acute CVA or acute pulmonary edema or acute myocardial infarction also. So even though the age is 55, a non-smoker, non-diabetic, and good physical activity, still a candidate to have a vascular disease just because of this high blood pressure. So that clearly shows his poor visits to the hospital to get the BP checked. Nowadays, no, even the BP apparatus are available at the homes in most of the places, even in the villages post-COVID era. So a lot of the BP apparatuses and also the glucometers are available even in the rural India. So I always advise my patients to get the BP checked at least once in 5 days or once in a week in all the hypertensive individuals. Even though they are the non-hypertensive, so I advise them to check the blood pressure in their family members at least once in a month. So what investigations would you like to do this patient? So do relevant investigations not to rule out the end organ damage. So the fundus, urine examination, as lipid profile, or the thyroid profile, electrolytes, ECG, X-ray, ultrasound abdomen, etc. Examination showed no evidence. What would you consider? Hypertension urgency or emergency? So here it is an urgency as there is no evidence of the end organ. So thank you very much.